Good morning, everybody. This is the interesting case I'm going to post from Dr. Ramesh Super Specialty Hospitals. This is interesting and useful to the residents of pathology, and this case is reported in our hospital. So, this is a 45-year-old male patient presented with cervical lymphadenopathy. Gross examination showed uniform gray white appearance. This is the microscopic appearance. See, in this case, you are seeing reactive follicles and interfollicular areas. This is one more field from the same case. See, in the first section, you have seen the normal structure of lymph node with reactive follicles, and majority of the areas are showing effacement of lymph node architecture. There are small lymphocytes which are uniformly distributed, and there are some cells which are larger, which has this binucleate appearance with prominent nucleolus appearing like RS cells. This is one more view of the same case showing interspersed small lymphocytes and larger neoplastic cells, some of which are binucleate with prominent nucleolus. Now, with this picture, what are the possible differential diagnoses we can think of? So, whenever you are seeing a lymph node pathology, neoplastic pathology, the differential diagnosis first is a secondary deposit from epithelial malignancy, then the second is Hodgkin's lymphoma, third is non-Hodgkin's lymphoma. So, first we talk about secondary deposit from epithelial malignancy. In the slide you are seeing, you are not seeing any epithelial look. Epithelial look means you will have a well-defined nucleus, a well-defined cell border. The nuclear cytoplasmic ratio is 1:4 to 1:2 depending upon the degree of differentiation, and the feature of epithelial tumor is some kind of cohesion. But in this particular case, you are seeing all dispersed cells. So, secondary deposit from epithelial malignancy is out of question. Now, the second is non-Hodgkin's lymphoma. Non-Hodgkin's lymphoma with partial effacement of lymph node architecture is highly unlikely, and in NHL, irrespective of the grade of the tumor, you will see monotonous proliferation, not small cells and large cells. So that leaves us with Hodgkin's lymphoma. In Hodgkin's lymphoma, the classic four types of Hodgkin's lymphoma, dear students, you all know, one is lymphocyte rich, second is nodular sclerosis, third is mixed cellularity, fourth is lymphocytic depletion, and then the other type of Hodgkin's lymphoma is nodular lymphocyte predominant Hodgkin's lymphoma. Now, I would like to add a point here in that whatever is the microscopy will be reflected in the gross also. If it is a nodular sclerosis variant of Hodgkin's lymphoma, or if there is any other case where there is nodularity, grossly also you will see nodular pattern, and especially so in nodular sclerosis you will see that firm appearance grossly, but this case it is uniform gray white and it is soft. So, now talk about the classical four types of Hodgkin's lymphoma. It is not nodular sclerosis because we are not seeing any sclerosis. Then all mixed cellularity, nodular sclerosis, they will have polymorphic population of cells. That means in the background cells. That means you will see lymphocytes, you will see eosinophils, neutrophils and plasma cells. But in this case, predominantly you are seeing small lymphocytes and larger neoplastic cells. So, mixed cellular variant is not a differential here, and nodular sclerosis also is not a differential here. Then lymphocytic depletion. The name says the lymphocytes have to be depleted, but in this case, you are seeing plenty of background lymphocytes. So, that leaves us only with lymphocyte rich Hodgkin's lymphoma, and the other differential diagnosis is nodular lymphocytic predominant variant of Hodgkin's lymphoma. Now, nodular lymphocytic predominant variant of Hodgkin's lymphoma should show in many cases nodularity, but in few cases they can be diffuse also, but predominantly nodular pattern. And there is no polymorphism, only small lymphocytic population. But in nodular LP type of Hodgkin's lymphoma, you have to classically show popcorn cells, which are not there. So, this is unlikely diagnosis here. That leaves us with lymphocyte rich Hodgkin's lymphoma. Now, lymphocyte rich Hodgkin's lymphoma also, the background is not polymorphic. You will see only small lymphocytes and you see plenty of RS cells. In this case, we are seeing cells which are resembling RS cells. So, with this picture, we made a diagnosis of lymphocyte rich Hodgkin's lymphoma, the classical type. Now, we have done immunohistochemistry. Then common leukocyte antigen CD45 is negative. CD15 and CD30 are markers for Hodgkin's lymphoma, and that clinches the diagnosis. CD30 is most of the times positive, but CD15 is positive only in 70% of cases. So in this case, we have CD30 strong positivity. Then, as you know, Hodgkin's lymphoma is arising from precursor B cells. So from the B cells. So all the B cell markers are positive. So in this case also CD20 is positive, and PAX5 there is dim positive in larger cells. Then Ki67 is positive in almost 30% of cases. So with this we made a diagnosis of lymphocyte-rich Hodgkin's lymphoma. So one question to all of you postgraduates: what is the characteristic immunophenotype of large atypical cells in this case? It is CD45 negative. Common leukocyte antigen will be negative. PAX5 positive, CD30 positive, and CD15 also is positive. Thank you.